Hello, everyone. It's great to be here again. We are here today with the Flint Community Webinar, your community resource every Friday at noon. Great to be here. Again, we're a partnership between Michigan State University and the Healthy Flint Research Coordinating Center. It's great to tell you about all the things we're going to be talking about today. Last week, we got to talk a little bit about adult preventative health. This week, we've got some really great people coming to talk to you about pediatric preventative health. I am Jennifer Edwards Johnson. I'm a family doc and I'm the community assistant dean at the Flint campus of the College of Human Medicine here right in Flint. We've got some really great people. Dr. Reynolds is here today, a pediatrician and the interim president and CEO of Greater Flint Health Coalition. We've got Dr. Brittany Taylor here today. She's an Alice Hamilton scholar and is an internal medicine and pediatric physician. She's at Hurley. We've got Nurse T here today. Great to have her on board. We've got Dr. Susan Wolford here with our medical moment and digging deeper into some things around RSV. Dr. Latressa Gordon. And then we've also got Jeff House, who's going to talk to us a little bit about Mott Children's Health Center. He's the director of Child and Adolescent Services and going to tell us all about the resources that they have. So we are packed today with great experts who are going to give us lots of really nice information. We're going to get started with a bit of a panel of some of these experts who are going to talk to us a little bit about pediatric preventative health. So we've talked a lot about what it means as an adult and what you need to do in terms of meeting with your healthcare provider, doing that preventative work of thinking about your health. Today, we're going to talk about peds and what that means in pediatric patients. So I think we've got Dr. Taylor here, and if we could bring Dr. Reynolds up, and Dr. Wolford, they were all gonna answer some really great questions that have been thrown our way. Awesome. So we talked about adult preventative health last week. Like I said, what does that look like for kids? What are the screenings we need to be thinking about? I know Dr. Reynolds has some thoughts about this.
Oh yes. And I will start from birth on, but really the most effective preventive care is a partnership between parents or caretakers and the provider. And that could also be the provider's staff. Because if your pediatrician or family practice doctor has a good nurse practitioner or physician's assistant, they can pull things out of you that you may not be ready to discuss, or they have the time to do that. I'm going to share a screen because the other most effective tool is parents having resources to handle the situation. And I'm not trying to make you all physicians. What I'm trying to do is give you resources where if you have a question in the middle of the night, and maybe it's not something urgent, but you want an answer, the American Academy of Pediatrics has a parenting website, healthychildren.org. And the reason I steer parents to this is it's in English, it's in Spanish, it has audio, which is in English and Spanish. Hopefully one day they'll figure out we have Arabic speakers and a couple other folks around. But this is the best tool that I've seen to refer parents. And I'm going to start at baby because that's the most critical time for most parents. But if you look along the edge of this, you'll see it's for every age and stage: baby, toddler, preschool, grade school, teen, young adult. And if you look at baby 0 to 3 months, you'll see they divide that. Is my microphone working? Okay. 4 to 7 months, 8 to 12 months. And you will see under each topic, there are skills that a parent would like to see, or if they don't see, they would be concerned about it. And you will see that there are 11 common conditions in newborn. You can get your questions answered, but most important, for each age and stage visit, there is a parent checklist. And let me see if I can pull that up. There's so much information on this. It's worth your while to spend some time scrolling through it. So let's see, ages and stages, child's checkups. See, for each checkup, there's a checklist. I'm going to skip to 2 months. So, of course, you're not seeing someone in preventive care if they're not talking about immunizations and continuing immunizations. Then there's the screenings, and those screenings are mainly focused on moms because moms bring the babies most of the time, but we can ask dads questions too. Feeding and development questions, and you see they cover common things. Like some parents may notice my baby's eyes cross in the first few months. Is my baby getting enough tummy time? And remember, it's always back to sleep. So as long as you are there with your baby, you can do tummy time and you're awake and alert. However, there's this common concern that if I put my baby on the belly, if he or she spits up, they might choke. Well, I've not seen that happen. And back to sleep or back time, especially when you're most important. And then there are questions you may have. And you know, most of us like to see that famous baby smile. And yes, they hear your voice. I think they smell you also. So they recognize who's there. They see your face. When can babies start solid foods? That's always a big bone of contention between grandparents and children. But breast is best. And really up till about 6 months, you can get by without solid foods. So let me see. Questions your pediatrician may ask you, questions you may have. So you see, it's pretty extensive, but instead of trying to swallow the whole issue of preventive care at once, you can go back to this website for a specific age and stage and problem and get the information you want. And if you have no problems, there's a checklist for each age and stage of development. And I think that's the way to get the most value out of a visit with your pediatrician, family practice doctor, or nurse practitioner. It will also prepare you so you won't be taken by surprise by some of our questions, like, why did that doctor ask me that? Well, we ask everybody these questions.
I love that you brought up the smile. I still remember as a kid when my siblings were born thinking that I had this effect on them and had made them smile when my mom was like, it's gas, like they don't even social smile yet, right? That's not a thing. They're 2 weeks, like that's not what they're smiling at. So thank you so much, Dr. Reynolds. I really appreciate that overview of where we can get really helpful information to prepare for the pediatric visit and think about next steps and really kind of work as a partnership with our healthcare provider, whether it's a pediatrician, family doc, a PA, NP, or what have you. I wanted to throw out some more questions. So Dr. Reynolds kind of set the stage of what it looks like and what we should be expecting in these well child visits a little bit, and what screening is reasonable or usual. Can someone allude to a little bit about what development or psychosocial or chronic disease things that parents might worry about? What are things that come up that we should be kind of thinking about or that you might be looking for as people who take care of little people? Either Dr. Taylor or Dr. Wolford, whoever has some thoughts on that.
I think the biggest issue is hearing. You have a hearing check done at the hospital, okay, but if it's not normal, they will schedule a follow-up. And still, if you think the child's not responding to sound, it's always worthwhile to get another checkup. Vision. Then if you notice differences in appearance that you don't see in the usual child, that's worth pursuing with your pediatrician.
Thank you. Dr. Taylor?
Yeah, so there are so many different things that we help with, not only in terms of preventative, but in terms of in that screening, but also caring for that after once we've identified an issue. So of course, hearing, vision, those are two huge things that we do, particularly in the first 3 years of life. We see you all the time. It seems like you're always here with us because we're looking for all of these little subtle different developmental milestones that the healthy children.org is actually really helpful for you looking for too. And those are the questions that we're looking for. So there's times when we know, oh, this is something that we're going to watch for a couple months, or something that I think this person might need a little bit more help. And so having a small delay in speech or motor, and we want to get them set up with those services as soon as they can, and we can help facilitate that. Other things that we do is we screen for other more chronic conditions, such as high blood pressure, overweight, or obesity. We also do screens for cholesterol in all children. We screen for lead. We screen for anemia. And we talk a lot about sexual health, mental health, and so many different things. And so even when you get outside of that 3, 4, 5-year-old, we're really looking for a lot of the developmental milestones. We are still looking for so much, from 5-year-old and on. And each year that changes to a little bit of different, something different that we might be looking for. Even if we're not doing vaccines, we're still trying to both educate you and your child as they have more autonomy. So they're used to using the healthcare system as well. So that way, when they get pushed off at 18 or whatever age it may be, they know how to call the doctor and make an appointment, different things like that. So those are the big things that we work on towards the end of their time with us. So it's not all just development. A lot of it is helping them learn how to use the medical system, and also screening for other things that may be more problems down the line.
I love that. I think the idea of empowering people to sort of take a part of their healthcare, journey, particularly early, and teaching them how to do that early makes a lot of sense. You mentioned a lot about developmental milestones, and I've got a 4 and a 7-year-old, and particularly in the pandemic, it was like, I know what the developmental milestones are, but like a lot of times my kids were home. So it wasn't like you got these comparisons necessarily to other kids. I was wondering if Dr. Wolford might talk a little bit about like, what are those developmental milestones? What should parents be looking for? What does that even mean?
So thank you so much, Jennifer, for that question. Yeah, so as we think about the developmental milestones, I think it makes us think about the anticipatory guidance that we give when families come for their well visits. And as I thought about this, it made me think. I ran down to my car and got my manual. So you get your new car, you get a manual. And, we often say that children don't come with manuals, right? But I mean, there are textbooks and there are websites, but how many of us have read our manual, from cover to cover? Probably not. We still need to go to an expert, right? And so pediatricians and family practitioners and nurse practitioners and those who have experience in treating children have read the manual. And so they can tell you a lot about what to expect as you are raising the most precious entity in your life, right? There is nothing more precious than our children. So collaborating with care providers who have experience in this area, I think is just the best thing to do. And keeping with the road sort of analogy or car analogy, anticipatory guidance made me think of Google Maps. I tried to actually find a real map, but who has a real map these days? So it made me think of Google Maps. You're going along and it says, danger ahead, or a traffic jam ahead, or it can tell you what's coming. And that's what I love about our preventive visits, our well visits, because I can sit with a family and say, okay, I'm with the 2-month-old now, and I will say, in the next few months, they'll learn how to roll. Be careful about leaving them on a bed or a couch that's any surface that's elevated without sides, because they'll roll off when you least expect it. All right, so now we've told people what to expect, and so they can prevent a concussion or something worse. Yeah, I mean, and this type of anticipatory guidance is important at every age. I mean, think about puberty. It's kind of an awkward conversation to have with children. I think many parents feel a little bit uncertain in there, but people who care for children are not uncomfortable with that. They want to jump in there and tell people what to expect about as puberty is coming. So it's pediatricians, family physicians, nurse practitioners, care providers who focus on children are a great resource that can help you know what to expect as you move forward in caring for the child and help you to avoid problems that might come about.
I really appreciate how you described the idea of anticipatory guidance and what people should expect as they move forward. And I think the example of puberty is so important because when you're dealing with, young adolescents, helping them know the next steps that are going to come, not just the parents, but them, right? So that they're not surprised or scared by those next steps. And I love the work that all of you do, because I think about my kids love seeing their doctor, and that relationship feels so important, and helping them think about those things that you just described. Parents sometimes struggle a little bit to talk about and can be uncomfortable. So we appreciate the expertise that exists there.
I love that you mentioned this relationship between the provider and the child, because that is so important. And often parents will learn things within those visits that they didn't know, not because they weren't bad, because they're bad parents at all. It's just because children don't necessarily share everything, particularly as they become teenagers. But I had a family this week who I saw them last year, and it came out that the child might have been experiencing some symptoms of depression and anxiety. Mum wasn't aware at all. And so it came out in the visit. We were able to talk about different resources that might help. They went and followed up on it. And this year, all smiles. Things were working out well. So I think that relationship that allows the child to feel comfortable sharing some things in that space is helpful for the whole family.
Absolutely. And I think it's so important, and it's great advice for the webinar, because it helps us think about, as parents or people in the community who love young people, hey, this is a resource for you. Your physician, your healthcare provider is a resource for you if you have questions, and you should be developing that relationship so that you can ask those questions when you're unsure or when they come up. I really appreciate that advice. So we talked a little bit about preventative and anticipatory care. What does it mean when we think about continuity of care or fragmented care? What are we talking about there? It sounds like there's visits along the spectrum that people should be going to. Why is it important that care isn't fragmented? I think Dr. Reynolds had some preliminary thoughts on that. And if you have anything to share, Dr. Reynolds, I'd love to hear your opinion.
We all have health insurance, and some of us can go wherever we want to. Some of us can't go to a particular place. But if we have a relationship with a provider, and I'll add their staff, their support staff, it's important. So if you have a question, you can get an answer. And yes, you may have to go to the emergency room. Yes, maybe you'll have to go to an urgent care place. But no, don't think because you went there, you don't need to contact your provider and let him or her know what's up, because that's important. Now that we have electronic medical records, sometimes we can actually get the chart and see what was done and make further recommendations and monitoring. So there's another real issue, and that is different types of providers, or different providers have different opinions about care. And so if you hear something one place, you really want to return to what we call your medical home to find out what's up. Now, sometimes, a house is not a home, well, an office is not a home, and sometimes you may have to change providers to get that relationship where there's good communication and accessibility. But this is the task, to avoid fragmented care, because you may have somebody addressing one aspect of your child's health, but they forget about 3 or 4 other things. And I know my family practice doctors and internal medicine doctors can agree with this also. So that's most important. If you can have someone who can sit down with you and review the whole picture, that's helpful. And I'm not claiming we know everything as a pediatrician, but we know people if we don't know.
I really appreciate that. And I appreciate the idea that you talked about earlier of the fragmented care and understanding what care your office can provide. And sometimes maybe you need to go to the urgent care or ER, but maybe you don't always, right? I think about one of the most frequent pediatric visits I see is for asthma. And I know my pediatrician offices in the area are so good at this, often because they have a nurse or someone in the office who is doing calls or doing little quick visits or leaving an opportunity for a phone call to the parent to say, oh, asthma's peaking up a little bit right now. The symptoms are a little worse. Maybe you need to do this. Can any of you talk about some of those examples where parents or people might be calling your office and distinguishing between going to the urgent care or maybe going to the ER?
So I feel like this is a really, really helpful thing, particularly with everything going on in terms of RSV and all of the other respiratory illnesses going on. A lot of times they're just calling the office. We can talk to you about what sort of things I'm going to be concerned about, particularly when it comes to someone's breathing or how much they're eating or drinking, what things I'm going to be concerned about, enough that I would say, you know, I think you need to be seen either in my office. I think you need to go to the emergency department. And there's a lot of things that we can do over the phone right there and then kind of help you right there and give you supportive measures and different things that we would recommend in terms of that, especially when there's a ton of misinformation in general about life, and you can probably Google anything, but you can get like kind of the firsthand knowledge. We can help you with dosing in terms of medications for a lot of things as well. And a lot of times if you call, we can make sure, you know, if we're like, you know, I think you do need to go to the emergency department or an urgent care for that, but we can say, but after you get done there, here, we'll set an appointment so we can touch base with you again and continue that care. Because any care that you're going to receive at an urgent care or ED it's just going to be that one time for that one small issue. And a lot of these things, say a broken bone or a sprain or a mental health crisis, there's going to need to be steps that are going to happen after. And by already being in contact with your pediatrician or your medical home, as Dr. Reynolds was saying, we are still in the loop with you, and we can seamlessly transition that from that one-time urgent or emergent care back to your medical home. So
that's amazing. So what I heard was call your medical home first, and then they can help you think about whether this is medical home or urgent care or ER. Is that fair?
That is exactly fair.
All right. I think one of the last questions that I wanted to throw out there is, we talked a little bit about this difference between adult health and kids health. And I wonder a little bit, why isn't it, what's the emphasis on kids health and how is it so different from adult health?
Well, a child is constantly developing, and the periods of time between changes and different stages is a lot shorter than in adulthood. And I'm not saying adults never change, because we go from childbearing age to non-childbearing age. We go to from adulthood to geriatrics, as I've recently entered. And so you have to change your whole approach to how you seek care. And for children, it's different. You know, adults generally will talk to you. Children, depending on their age, can't talk, won't talk, or, you know, you have to read between the lines. Well, you have to do that with adults too, don't you? But it's a communication issue also. And then when you look at an office, an internal medicine doctor who's just practicing internal medicine may not have all the vaccines that are required for an effective children's visit, may not have the equipment that's built especially for child examination and care. And I'll stop there.
No, I think that last point that you made is such an excellent point. And I think of my 7-year-old who will talk to me about plenty of things, but, you know, gets in the car after school and is like, school's good, right? Like, that's it. not like math, science, no elaboration. So I appreciate the skill that it requires in different spaces to sort of get a little bit more of that information out of your population. So thank you for that. Any last thoughts from this really wonderful team of experts?
Oh, yes. Hi. As Dr. Reynolds has spoken and also Dr. Taylor, we always say children are not small adults. They require, different medication dosages as they are, and different treatments due to their anatomy. Also, when you come into like I worked ER for years, we do what's called sample. They'll want to know your signs and symptoms that your child is having. Is there any allergies, the medications that they're taking, past medical history, immunizations, events leading up to the event. So those are kind of things that you'll be asked when you get there to help paint the picture of what's going on with the child. But, we always say children are not small adults.
I really appreciate that. And Dr. Gordon's going to come back and talk to us a little bit more about RSV and what she's seeing in the community there with Dr. Wolford and Nurse T. So we've got more. That won't be all that you hear from Dr. Gordon. She's going to talk to us a lot more. I want to really thank this panel for your wonderful expertise, and definitely please answer us next time when we call, because you've provided such great expertise that we'll be asking you for more. I want to pivot a little bit. We've got some wonderful, more expertise in the house. We've got Jeff House, who's our Director of Child and Adolescent Services over at Mott Children's Center. And he's going to talk to us a little bit about what resources they have in the community and are available to provide in the community. As we think about these developmental milestones and the potential that maybe you need a little bit of help and resources, helping your kids meet some of those milestones, Jeff is going to tell us a little bit about how Mott Children's Center is a wonderful resource in the community for accomplishing that. So thanks so much for being with us, Jeff.
Thanks for the invite, and thank you to the previous panel. What great expertise, and it's an honor to be here to be part of this. So Mott Children's Health Center was started in 1939 by Charles Stewart Mott, who realized at that point that there would be families in Genesee County that didn't have health insurance. Now, for these generations on this call, this was before we had Social Security, Medicare, Medicaid, or any of those social programs that our world and community just couldn't live without at this point. So we are a full certified pediatric dental and medical home, and we have the approach of mind, body, and spirit. Yes, we have definitely health, physical health, but we also know that if we don't help with the social determinants of care, of safety issues, of food, of access to care, and those types of things, then families will struggle. And I think one of the biggest issues that we have in Genesee County is access to care and trust. So we try to work definitely with continuity of care to work on and really bring families in or meet them where they're at and really assess all of the family's needs. So the services that we provide, we have a primary medical. So we have 2 pediatricians and 2 nurse practitioners that work full time. And then we have 3 specialty clinics at this point for pediatrics, pediatric cardiac, pediatric lipid clinic, which is a metabolism clinic. And then we have a new ENT coming in also that is here also to do more of the advanced pediatric ENTs. We partner with everyone, every provider in the community. We are not here to compete against anyone, but to supplement what is not here in the county. We would, because of access to care, our goal is to make sure that families don't have to leave the county to get the care that their kids need, if at all possible. So that is really one of the basis core philosophies.
That is,
pardon me?
No, I was going to say that is amazing. And if you, I don't know if it's my volume, but if you could yell a little bit, because I think we're having some technological difficulties. So I've gotten everything you said and all the wonderful stuff you already said, but.
Nope, that's great.
Perfect.
I have a new computer that isn't voice friendly. It kind of dulls me and we can't figure out why. So that's great.
No
So in addition to that, we also have a behavioral health program, which now we have full-time, nine full-time behavioral health specialists Two of them go out in the community. So we have clinics at the Boys and Girls Club, and we're now working with another partner to develop a clinic there so we can meet kids and families where they're at with behavioral health. And then we have a child psychiatrist. So we now have full-time psychiatry, and we're recruiting for another one because the need is so great in the community for behavioral health and child psychiatry right now. We also have pediatric audiology. So all newborns that come in, especially newborns that have Medicaid, we do all the screenings for that too. And we know that if there is a hearing issue with the child, if we don't get in front of it before 6 months old, we'll start to have developmental delays already. So we're very, and we work with GISD and the school systems for their audiology programs also. And then we also opened an outpatient pediatric rehab center. So we have PT, OT, and speech. And we're specializing in that. Our speech language pathologist went down to become certified in specialized feeding because there's texture issues, taste issues, those types of things in newborns with the developmental clinics, as well as neurodiversity. So we see a lot of kids with neurodiverse issues, and we've identified an incorporated play project. So all of our therapy through our physical therapy is done through play project. And the funny thing is when we see these kids that are unhappy and crying, it's because they don't want to go home because they're having a great time here. And Dr. Reynolds brought a great point up, and we're developing relationships that we're part of that family because we want them to be able to trust and know that they can call us at any time for any issues they're having, and we will try to get them resources or in touch with them, whether it's short-term or long-term. We have opened a food pantry and a clothing pantry to meet immediate needs for our patients, but then we get them into sustainable sources through CHAP, which is a great organization, and through the Greater Flint Health Coalition also.
Can I ask you a little bit, Jeff, about you mentioned neurodiverse patients, and I think we both know a little bit about what that means. Could you talk to us a little bit about what that means and what your services are meant to help with?
Sure. So let's take autism, for instance. And there's a lot of different types of autism and degrees. In our rehab center, we work with autistic children. We develop a plan of care. And then what we'll do is if they need to be alone when they do the therapy, is it tactile? So whatever they're having problems with, and I could quote a few patients that the parents are just looking at us and crying because their kids were nonverbal, or they would point, but they wouldn't speak, where now they're speaking and they're working with those types of situations where it's just a one-on-one, but all of in our rehab, the parents have to be part of it. They have to be part of it because we're teaching them to do the therapy that we're doing here so that it's a consistent thing. And it also teaches the parents how to relate to their children. And now we're going to be developing support groups for certain diagnoses. So that's one neurodiversity. There's also with cystic fibrosis and some of those types of things, even though that may be more of a respiratory thing, diagnosis, it also has some neurodiversity to go with that too. So it depends on what the diagnosis is. And then we work with GHS constantly to refer patients that either we're not qualified to or we don't have room for to refer there also.
That's fantastic. So you have all of these great resources in-house. How would someone like myself or Dr. Reynolds or Dr. Taylor or Dr. Gordon, any of Dr. Wilford, any of the amazing people who were on earlier, how would we get a patient who we might have identified as needing your services over to your facility?
I can give you the phone number, just ask for, or there's a lexicon to push a number and you get to the right department that say that it is for rehab, or okay, that you need to refer to an ENT. We'll take a referral right then and there. And our goal is, because access to care is such a barrier, if we can't get a child in for an assessment within 3 weeks of a referral, and that goes to every department we have, however, dental is a little dicey at this point because the need is so great. We will start looking at adding staff because we know that families can't wait months to get in. I mean, if you have a child in crisis, we can't wait 3 months to get them in here. We need to get them in right away. We also set aside urgent visits in every department. So if a child's in crisis, we want to be able to see them right away. We also have sick visits. So if if a child needs to be seen right away, we can do that too. So we don't want them to go to the ER or to an urgent care for the continuity of care, if they don't have to be. But to make a referral for us, you just need to call our number and we'll take the referral on the phone right then and there.
Fantastic. We'll get that number in the chat during the rest of the webinar. Really appreciate that. You mentioned access to care as a really big barrier in the community. Are there other barriers that you all have identified that you're working through some programming that you want to talk about?
Yep. So we work under the PACE, which is the Positive and Adverse Childhood Experiences. So we screen every child and every family for that on a brand new child and then annually for that. And then we also work under the Trauma Informed. So when we look at access of care, it's things like not only transportation, but do you have gas money for that? Are you safe? Do you have a safe place to go? Do you have enough food? Those types of things. That's why we opened our temporary food pantry, so we can get them food for 3 to 5 days, and then get them in touch with the sustainable thing. The other thing we also do is any families that don't have insurances, we have an insurance specialist, and we're working through connecting kids to coverage through the Greater Flint Health Coalition to get their insurance as soon as possible so that they don't go with any gaps of care. Here, we would take them anyway and see them, but we really want to make sure that they have all the resources that are available to them. We also put in we have a special contract with Rides to Wellness so that we can provide just MOT patients to pick them up and bring them back and forth to get to their appointments also. So for us, the 3 top challenges that our families have, one is trust in our community because of our history with the water crisis and stuff, that we have to break those barriers down, but access of care, and then trying to navigate through the whole healthcare system as a whole. If you can imagine, I know most of the, all of you doctors that are on here know, there are families that have multiple challenges. Well, it's hard for us in the system to navigate the healthcare system every now and then. So we have a chronic care manager and caseworkers that also assist families in navigating through the healthcare system or getting resources in the community.
That sounds amazing. And we see we have this number in the chat. Are there any upcoming events or initiatives that you want to highlight or talk about in terms of things that are coming up in the next few weeks?
No, unfortunately, in the next few weeks, because we have so many children with RSV rising and those types of things, we're really, and this is our busy time of year anyway for cold and flu season. And when kids go back to school, that's our busiest time for behavioral health too, because that's when it's identified that maybe there are some potentials that we can help families with so that the kids can stay in school. So those are the things that we're working at.
No, so you're like, this is our busiest time of year. Why would we have events or screening?
We can't do that right now, yes.
Get it, right? I want you mentioned the positive ACEs, and ACEs, we all know ACEs is a really important thing and really, really important screening tool. I wondered if you would talk a little bit about what that is for people who may not know and what it means.
Sure. So well, it's ACEs, but now it's also PACEs. So ACEs, of course, is adverse childhood experiences. And there are some great movies, and we're certified to do one of the movies, which is Resilience. And what we've proven through over a 20-year study is that if we can help children and young adults that go through a traumatic experience in their life, like they've lost a parent or their house burnt down or they were sexually abused or something like that, and we can identify that and help them deal with that emotionally and physically, it will result in a healthier adult. We have found, and it's been proven, that if we don't, it will, when we get to adults, we have increases in addiction, obesity, depression, mental illness, diabetes, those types of things, because if we haven't dealt with the trauma, eventually it's going to come out and anticipate or present itself in other physical ailments. Additionally, now it's called PACEs because if we can show the positive experience people are having and have them learn by that, it's a stronger, more emotional bond for them as well, so that they'll be a healthier adult and be able to process things like anger issues or a lot of times what we see now, our kids are like, well, they disrespected me and their resolve is violence. Well, that's not the case, right? First of all, what we teach is how can they disrespect you if they don't even know you? So it isn't a disrespect. People could be rude, but don't take it personally. So we do also classes that we're teaching kids and now parents on how to work through some of that. What is puberty? What is body image? Anti-bullying, those types of things. All that's wrapped up into our PACE or ACEs philosophy that we apply to every patient here.
That's fantastic. And those classes, those are things that can people think about how to sign up from your website or the classes that you just alluded to?
Yep. So right now with our parenting classes, we're doing MOT patients only, but in 2023, there will be where anybody can sign up for those. And we're partnering with community partners, not to compete and recreate the wheel, but to grow their programs at the same time. There are some great parenting classes already being done out there that we want to be able to help refer to or even sponsor and host here. So yes, that will all be on the website.
Fantastic. So you've talked about an abundance of resources that you all provide, your PT, your OT, your speech, your audiology resources, abundance of really amazing resources, including dental. And I don't know that we have another huge dental resource in the community. A couple seconds, maybe you could chat about some of the stuff that you're seeing people come in with for that and how the dental side of your practice has been reaching out to people.
Yep. So our dental practice goes from birth to 19 years old, unless it's a special needs child, and then we'll take them for life. So we do have a couple 40-year-olds and actually a 68-year-old that's been coming to Mott for 68 years. So that's pretty impressive. But what we do there is we do mostly at the beginning preventative, proper teeth, brushing, what does sugar do to your mouth, that type of stuff. We have 5 hygienists that work full time. And then of course we have a full dental program. The issue that is because sometimes there are behavioral issues and we have to take a child to OR, there are no OR spaces now. So that could be, 18 months to be able to get a child to the OR. Well, families cannot wait for that. We also are the only pediatric dentist that will handle emergencies. So we do all of the dental at Hurley Hospital's emergency room, and any urgent, no child should be in pain. So during the pandemic, when all the dentists had to shut down per governor orders, we did not, and every urgent child came to us. So all of the dentists in our county know that we will see a child after hours if we need to, if they have an abscess or something like that. So we're real proud of that fact too, but we do not turn any child away that's in pain.
That's what I was looking for. I had heard about that resource during the pandemic and I was trying to get you to talk about that because it was so amazing, right? That, we don't think about pediatric dental emergencies so much, and this resource of having this after hours availability and just emergency service was really nice to have available during the pandemic. So thank you to you and Mott Children's for providing all those services.
That dental staff, I will tell you, they actually were calling and going, we are not closing. There will be kids that will need us. I'm sorry what the governor is saying, but we have to do that. And we didn't. I was very proud of that team also. And just a little tidbit, there was a banner day where we had 30 urgent children during the pandemic for dental alone. So it was a definite need that they rose to the occasion and got. So thank you for that. And we will continue to do that now.
Are there any last comments that you want to make before we pivot? I want to give you an opportunity to shout out your team and just, talk about the great work you do. So we got a few more seconds if you have any last comments.
I really appreciate that. But really my last comment is thank you to everybody on this panel here, because we do partner. And like I said, we're not here to compete, but there are some great things happening in Genesee County that will pave the way for healthier adults if we work with these kids now and build trust and break down some of these barriers and social determinants of care. So thank you for inviting me, and thank you to everybody on this call for all the great work you do.
Thanks so much. Jeff is an exquisite partner. He's helped us think about how we can get med students involved in the care of pediatric populations. So always great to see you. Thank you so much for being a great partner. We've talked about, thank you. We've talked about pediatric preventative health. We've talked about extra services that can be provided by people like Jeff and Mott Children's Center and the community. The big looming thing that we're not talking about, sort of the elephant in the room, is RSV. And it's a big looming thing for me because my kid just got over it. So it's something that we're definitely seeing in the community. I'm seeing it in my office, and I was hoping to bring back our wonderful Dr. Susan Wolford to dig a little deeper into RSV, what she's seeing, what she knows about it, and just talk to us about what's going on with RSV. Why is it such a big deal?
Thank you so much, Jennifer, for raising this topic and giving us time to discuss it. And so we are going to go into our digging deeper session on RSV today. And I am so pleased to be able to introduce to our panel today, Dr. Margot Norton, who is one of my colleagues at the University of Michigan, where she's also one of the education leads for our pediatric residency program, particularly around advocacy and QI. And she is like one of the go-to people at our clinic. When I have questions, I go to Dr. Margot. So I am happy that she can join us here today to dig into this, to talk a little bit about RSV. So Margot, tell us, what is RSV? We are hearing about it on the news all the time. What is RSV?
So RSV stands for respiratory syncytial virus. So it's an RNA virus. It's something that infects the cells within our airways. And after going into cells, our immune system responds with inflammation. And so then it causes some symptoms. There's two different airways that can be affected. So your upper airway, so that's what causes those cold symptoms like a runny nose or nasal congestion. And then there's your lower airways, your lungs. And that's where the infection can cause difficulty breathing. Most people with RSV have mild symptoms, so it looks kind of like a common cold. Some people get a fever, but not everybody. And then in some special populations, it can cause more severe disease. So in young children, this is called bronchiolitis, which is inflammation of those lower small airways.
That's phenomenal. And that just to describe, that inflammation is what narrows those airways and makes it hard for them to breathe, right? It's because their airways are so small, and then all of that congestion that those little ones get. So thank you for sharing about, so now we know what it is and what it looks like in different age groups. So how do people catch it? Like, are all of us at risk? How could we catch it?
Yeah, so there's really two ways that you can catch RSV. So one is respiratory droplets. So that's those, droplets that you may be able to see, not be able to see when somebody coughs or sneezes. And those droplets can also, have viral particles that can be on surfaces. So, door handles or utensils or toys or different things. So those are the real two ways that people get RSV, is by having, respiratory droplets that someone coughs or sneezes, or touching something where those, respiratory droplets landed.
So as you say that, I just can't help but mention some of the things that Dr. Reynolds would always talk about on this webinar, right? So if it's spread through respiratory droplets and it's spread by things that we touch, we know, those of you who've been listening to this webinar for a while, we know how to protect ourselves a little bit from that, right? So keeping good hand hygiene, wiping, using hand sanitizer, washing our hands, those kinds of things will help hopefully protect us, and wearing a mask. So now we know how it is spread. And we know a little bit, can you say a little bit more about who's at risk? Like, who is more at risk to suffer from severe RSV than others?
Yeah, so young children and older adults are the two populations that are more at risk of RSV. As a pediatrician, the younger children are kind of my wheelhouse and who I take care of. So the younger the child, the more likely it is that they have severe disease from RSV, that bronchiolitis, that inflammation of those lower airways that we were talking about. You can imagine that the smaller the child, the smaller those airways are. And so they're more at risk from that standpoint. Smaller children also have a little bit less reserve than an older child. You know that when your baby is sick, it's a little bit harder to deal with than when your 5 or 6 year old is sick. They have a harder time feeding if their nose is all clogged up. It takes a lot more work for babies to feed if they're having trouble breathing. So younger children are a big population that's at risk. And then you also think about older adults, like, the grandparents, et cetera. So, young kids bringing home a respiratory virus from daycare and then infecting, a grandparent that may live in the household is kind of those two populations that are at risk.
Absolutely. And as you think about younger children, particularly maybe we would consider those who are preterm and premature babies are particularly, can you say a little bit about them?
Yes, definitely. So, kids under 1 are most at risk. And then, the younger you get, the more at risk you are. And then preterm babies, their lungs are less developed when they are born. So they are already kind of at risk from respiratory viruses. And you can imagine this respiratory virus that gets in those lower airways, they're more at risk. They've got smaller lower airways, they've got less reserve.
Absolutely, absolutely. And one of the things as we get into those who are at risk, I just want to veer a little bit to how we protect them, right? So we, what can, like, exposures at home that might be things that we can cut down to help people who are more at risk, the preterm babies, the young children. What kinds of things can we do to protect them from this?
Yeah, that's a great question. So I'm so glad you've already mentioned hand washing, because hand washing is so important. And I remember when I was a new mom at first, I was always telling people, okay, if you want to hold my baby, like, wash your hands first. So hand washing is really important. Also, if there are family members who have, even very, very mild symptoms of a cold, or people that want to come visit or see your baby that have very mild symptoms of a cold, especially during these peak times when RSV is really high, trying to keep those folks at a distance from your baby, especially not like kissing or touching their face, getting really close to their face. That can be really important.
Yeah, and those who smoke, keeping away and people, well, I wouldn't say keeping away people who smoke, but the smoke away from the child is what we want to do, right? Okay, definitely. So how do we know when a child should be taken to the emergency room? Like, what should trigger a parent to say, aha, I should take this child in?
That's a great question, and one that I get a lot in my practice, or when on Wednesday I was on our phone call service for our after hours care, and this is a conversation that I had over and over. So the first thing that we look for is increased work of breathing. So that means, does your child look like they're breathing faster than normal? Do they have, you look at babies or young children, and do you see their belly moving up and down really quickly? Do you see in between their ribs? Can you see that sucking in every time they breathe? If you're looking here at their trachea and their neck, do you see this part kind of sucking in deeply every time they breathe? And then also looking at their nose to see, are their nostrils flaring every time they breathe? So that's when someone says, do you see increased work of breathing? Or if you're talking to the nurse and they say, is your child having increased work of breathing? That's what we're talking about. And that's really the main thing to look for. The other things that I think about are, is your child getting dehydrated? So because RSV can clog your nose or make you breathe faster, that can also, especially for babies, make them more dehydrated. You also can have a fever with RSV, so that also puts your baby at risk of dehydration. So really paying attention to, how many ounces of formula or breast milk or whatever your child is drinking have they had compared to what's normal? How many times have they been peeing? Is that a normal amount for them, or is that less than normal? And if you're not sure about that, your pediatrician is always, or your family doctor or your other provider is a great resource to help you figure that out. And then, is your baby lethargic? So are they so sleepy that they can't, play or interact with you or eat? They're not smiling at you, at all. You're really not able to interact with them the way you usually do. So those are the big things that I look for.
That's phenomenal information. Really, really helpful. So before we're going to bring Dr. Gordon and Nurse T in just a moment. Just before we do, a couple quick questions. Can you get RSV, flu, and COVID?
So theoretically, you could. You could get them all at once. And, you know, one thing that we haven't talked about is there isn't a vaccine for RSV, but there are vaccines for COVID and for influenza. And so when we're trying to think about protecting our kids, thinking about doing the things that we can to protect them, like vaccinating them against COVID and influenza, and vaccinating family members and creating that cocoon of safety where all of the caregivers and everybody around them is also vaccinated against the things that we can protect from.
Wonderful. And finally, before we go over to Dr. Gordon and Nurse T, why do you think COVID is, I mean, not COVID, which is another question. Why do you think RSV is so much worse this year?
It's a great question. You know, we always see a peak of RSV, but this peak has come much earlier than we expected. And we don't know when the peak is going to end. We don't know if that peak is going to end up being higher than, you know, the typical numbers that we see at our peak. We know that a lot of us have been doing a really good job of staying away from each other and isolating when sick. And now things have returned a little bit more toward normal. So it may be that we're seeing respiratory viruses circulate more because of that. But we really don't know yet. But what we do know is that RSV is a virus that we see and that we as pediatricians have seen for many, many years, and we, you know how to care for. And, you know, talking to your doctor's office if you have concerns, or taking your child into the hospital if you're seeing those concerning signs is very appropriate, because we as pediatricians, we as, you know, family medicine doctors and other providers, we know how to take care of this illness.
Wonderful. Thank you so much. Stay on with us. We're going to just pop over to Dr. Gordon and Nurse T. Tell us what you're seeing in the community with RSV.
Am I going first or you, Dr. Gordon?
You go ahead, Nurse T.
In the community, we are seeing increased awareness of patients and family members and mothers being frightened. They're panicking because they're afraid, because the virus kind of like is similar to some of the same signs and symptoms of RSV. So the families is thinking, oh my God, my child got COVID. And at the hospital, we are just running out of beds, running out of space. I mean, our ER is populated to capacity, and we are doing the best we can. I know the other day I was listening to Dr. Yagi, and he was saying that for the first time, we are experiencing a volume that we haven't had to experience before. And so one thing that he wanted me to just reassure the community is that we are doing everything we can to carefully and safely take care of all the children that's coming in. And before I turn it over, I just want to highlight a few things too, as far as the severe risk. Young children with heart or chronic lung disease, weakened immune system, medical conditions like neuromuscular disorders or immune systems, and even with our seniors or anybody that have any underlying heart or lung disease issue, especially now at this time. We have so many asthmatics, so many patients with COPD, knowing that they are in increased risk. And as far as with the prevention, making sure that we remember to keep those safety measures in practice, watching doorknobs, sanitizing, still covering, because it's contact and it can last. So making sure that we're still following the same safety guidelines that we did with COVID. But we're here to take care of you and do the best we can. Now I'm gonna turn it over to Dr. G.
Yep, we're gonna give Dr. Gordon the last word on RSV in the community. Tell us.
Yes, in the community, as people may know, that Ascension Genesis has transitioned their pediatric floor, but they are still taking emergency pediatric patients. So if you are located near that hospital, make sure just not plug out, but it's also McLaren, because Hurley is currently the only hospital in this area that has a pediatric floor, ICU, and ER. But we at Ascension, they do take patients, pediatric patients. They're the nurses there. I used to work at 15 years, emergency room nurse, ENP certified, that's an emergency room nurse, PAL certified, and trauma certified. So when a patient presents there, if they come with RSV, they will be treated, stabilized, and transferred to the appropriate level of care, pretty much like Dr. Reynolds and Dr. Margot. Okay.
Yes.
Okay, so spoke on the different symptoms like the lower respiratory illness, the most common to what it starts out as mild, as you stated, and then goes to bronchiolitis into pneumonia. That's where we get into the trouble at. So knowing the difference, watching the symptoms, starts out usually mild, usually about 3 to 5 days. That's when the most severe symptoms can kick in. So watching, like I said, the child's breathing. They start grunting, knowing that's like a bad sign, grunting, wheezing, and just seeking out your primary care or provider urgent care. If they're grunting, emergency room, the color of their skin, if their lips, they're turning blue or anything like that, just noticing, watching out for the different symptoms. And like they went over everything about the preventive care. And there also is, I don't know if you could speak on the antiviral that sometimes is given to like the pediatric patients that have premature or are known to have immunocompromise. You can talk with your provider regarding that as well.
Thank you so
Really
much.
excellent points. Thank you so much, everyone.
Excellent
Jennifer.
panel next week. We'll be here with mental health and Genesee Health Services. Quick reminder for our social workers to fill out the continuing medical education credits. The instructions are right there. Thank you for joining us. Thank you to our panelists and their wonderful expertise. Stay healthy. We'll see you next week.